Hello, and thank you for joining our e-seminar entitled Dizziness in Aging, Rehabilitation of Chronic Nonspecific Symptoms, presented by Mike Studer from Northwest Rehabilitation Associates in Salem, Oregon. Mike received his physical therapy degree from the University of Missouri-Columbia and his post-professional MHS degree in physical therapy with neurologic emphasis from the University of Indianapolis. Mike is a recent past chair of the Geriatric Section's Balance and Falls Special Interest Group and is now the vice chair of the same group for the Neurology Department. He has served as vice president of the Neurology Section and has been board certified as clinical specialist in neurologic physical therapy since 1995. In 2001, Mike received the Neurology Section Clinician of the Year from the APTA. In 2014, he received the same award from the Geriatric Section of the APTA. Without further delay, I'll now turn the presentation over to Mike.
Thank you, Mary. I'm very much looking forward to delivering this presentation on chronic nonspecific dizziness as individuals age. Let's see if we can work together today to collaborate on how to diagnose and to treat these individuals toward a successful functional recovery. As you can see on the outline today, we've got an aggressive and optimistic agenda here that we're going to try to cover. And rather than insulting you by reading the outline to you, I'll let you read that. But do know that we're going to try to define what dizziness is and is not, look at vertigo and contrast that with dizziness, talk really about the subjective findings that you'll have in a patient that has chronic and nonspecific dizziness as they age, take a look at a treatment algorithm, and look at some videotape examples of how to apply treatment as well. So, as you've seen there with the outline, we're going to start off with really taking a look at this whole understanding of what chronic nonspecific dizziness is, and really in introspective view as to the incidence of that before we move on to physiology and the examinations. So the significance and incidence of dizziness, you might be a little bit surprised as to how many people out there actually experience dizziness. So let's take a look at that. Research tells us, especially some well-cited work by Timothy Hayne, that the increase of dizziness is really more prevalent after the age of 40. And it might shock you a little bit to see that about 15% of individuals greater than 40 will experience dizziness at some point. Now, we break that down into different diagnostic categories of where their dizziness is coming from, and you can see that for yourself then on this page. Might be helpful for you to learn some of these statistics for future patient or even physician education points. We certainly all understand the significance of dizziness, and we know how that plays a dramatic role in many individuals' falls, contributing to their losses of balance. And we all know the consequences of imbalance and falls, but just to state those by a dollar sense and really look at it as an epidemic in the United States and obviously worldwide as well, a few statistics for you to be able to further elaborate that point for others. So it's a quite commonly cited statistic that about 1 out of every 3 persons over 65 fall each year. So 1/3 of people over 65 are going to fall. And unfortunately, a number of those are going to lead to that individual passing away directly from that fall or indirectly later after hospitalization and with secondary injury of the fall. So the statistic that's commonly cited would be 38% of unintentional deaths are due to falls. And as you can see the next statistic there, 1.64 million people per year treated in emergency departments, and that's a United States statistic as you can see at the top of the slide. The projected cost of falls and related care to rehabilitate from falls. That would include surgeries for hip fractures, hospitalizations, and rehabilitative care by 2020 is projected to be $43.8 billion. Certainly a significant part of healthcare expenditures and our gross domestic product in this country. So specifically now, turning our attention toward dizziness, we understand that many people just feel that dizziness is an obligatory symptom that's going to occur with aging and that it must be accepted. Other individuals in the medical profession as well as outside the medical profession certainly would hold the belief that dizziness is just something you have to accept as a sequela of or a side effect of medications. However, we find that when we're working with individuals that have nonspecific dizziness that is increasing as they age, we don't really attribute the aging process or the medications to the cause of their falls when we are astutely diagnosing this condition and treating it toward its resolution. Obviously, some people are going to have the medication effects, and then there are other conditions to rule out that I've listed for you here, very important and sometimes emergent or crises-based conditions that we would want to rule out and ensure that we're going to be successful in treating because we've diagnosed things correctly. But as we move on throughout the presentation today, I think you'll find that you're going to be more well equipped in understanding how to rule in and rule out medication, as well as some of these other concomitant problems or completely different conditions after you've gone through the presentation. So when we are trying to rule in chronic dizziness, many of the things that we need to be able to do are rule out other more serious conditions or sometimes other very straightforward and treatable conditions that are not purely just dizziness. One of the first things you'll want to do is take a moment to attentively listen to the individual that is explaining their conditions. Many times you'll actually hear one of the three top bullet points on this slide or a sentence that is at least using different words to affect the same communication. I feel dizzy most of the time when I move. It's a weird feeling in my head. Sometimes they'll describe it as pressure. Sometimes they'll say, after I've been moving for a while, I still have that sensation when I'm sitting. The reason why we take a look at some of these sentences as really being the most descriptive and leading us most preferentially toward dizziness is because we understand that if a person only feels this sense that they describe as dizziness when they're in motion, sometimes they actually mean imbalance and they don't mean dizziness. And we'll get to more details about that when we talk about the flavors of dizziness. Also, we have to understand if there's just a positional movement when they are lying in bed, we need to think if they're saying things about the room spinning or the world turning or my eyes are fluttering, and we look a little bit more toward vertigo in many of those cases. Again, that'll become clear, but that sets up the context for why it's so important for us to listen attentively to the patient's descriptions. Now, to rule in chronic dizziness, we're going to want to rule out benign paroxysmal positional vertigo, and that's why the next bullet point there is positional testing is negative. Also, without a great deal of ado and description, you'll want to obviously clear orthostasis, and you should be very astute in how to do that as well. Obviously looking at atrial fibrillation and tachycardia, because as we saw in Dr. Haynes' listing of the different reasons persons have dizziness, we know cardiac is among the leaders on that. Medication-induced, and I'll talk with you more about that, about how to rule that out. And then we also want to ensure that to be accurate with chronic nonspecific dizziness in an individual as they age, that we should be expecting that they're describing a progressive and gradual onset, not a I woke up one morning with, but oftentimes I used to have it fleeting and now I have it more frequently. A differential diagnosis in chronic dizziness could include the following columns. To rule in dizziness, we look at the detailed interview of what the patient is describing to us, as I referenced in the last slide. We look at their motion intolerance or motion sensitivity. We would need to investigate a visual provocation, and we can look through that a little bit too. Measures such as the dynamic visual acuity test. We would use some motion sensitivity testing that we could use with motion sensitivity index and quotient. And then we also would look at medication-induced, such that we're looking at times of day when the half-life of the medication that they're taking is at its highest point. Does the dizziness go away when they are due for their next level of that medication, etc. So to rule in dizziness, we want to take a look at some of those things. But then to rule out others, we definitely want to do a thorough neuro examination with ocular screening, as I already referenced, the positional and orthostasis, but then also balance testing to look for ataxia and other possible causes. So the symptomatology, to be clear and even a little bit more precise now about geriatric dizziness and chronic nonspecific, would be, as I've stated, a gradually and more disabling set of symptoms without an acute onset. Again, could be that feeling of pressure in the head, nausea, could be described as dizziness if they were really handing it to you well. Many times these individuals will describe imbalance and dizziness, but you need to ensure that they're not just talking about imbalance. Many of these individuals will still experience some precipitous symptoms when they are actually sitting after they've been moving. If you just feel that you have imbalance, that should be completely removed. That sensation should be completely stopped and done and resolved when you sit down and you will know that you're steady. But if you have dizziness, that may last with you for some period of time, seconds plus. Obviously, we've made several references now to the need to rule out vertigo. We understand that many of these individuals will be asymptomatic once they've been seated and they're still, but if they're still and they're balanced and we begin to ask for some head rotation, typically head rotation, sometimes also with head nodding, these people will have their symptoms brought back up. If you actually are only feeling unstable or unsteady or imbalanced, you should not provoke your symptoms by sitting still with head motion. So that's a great way to start to rule in this nonspecific dizziness. And as true with many other conditions, but also with geriatric dizziness, these individuals should express and display a severe visual dependence, which is another reason why we need to do the balance testing. Usually a modified clinical test for sensory integration and balance will give us a great deal of information. When we look at the pathophysiologies of dizziness, we understand that essentially we've got three different inputs of sensory information that the brain is going to use as an equation to create a reference of balance. And as listed here, and with the pictures to complement that, we have visual, vestibular, and somatosensory. So you can understand when we have a mismatch of inputs, if your eyes are telling you one thing, but one of your ears, one of your inner ears to be specific, is in disagreement, that will be resonating as a sense of dizziness for that person. Now, how they perceive dizziness and what terms they use and even the senses that they feel are quite individual. Two people can have the same exact condition and one of them can tell you that they feel that they have dizziness. One of them can tell you that they've got pressure in their head. Another one of them can tell you that they feel like they've got nausea. How you present with dizziness is quite individual and does not entirely dictate different conditions of dizziness. So with that stated, we also understand the pictures here that you'll see of the vestibular apparatus and the cupula, There's a lot of complex matrices here that have to go together for that full agreement, and it's actually, once you get to study it, quite surprising that we're usually in full agreement and have no symptoms, because there's so much that could go wrong with all of these very small and interconnected structures. So here again, of the 3 inputs, we're seeing vestibular. And then finally, we're looking at some figures here that represent the somatosensory, which is complex and shouldn't just be written off entirely, because we have sensory receptors that are really of the stereographic nature, tactile, pressure, nociceptors, joint receptors, muscle spindles, and you can see how those things traverse and, as you probably recall from school, end up processing mono and polysynaptically in the spinal cord, and then obviously up into the brain as well. And you can see those Pacinian corpuscles that you wanted to forget about, etc. But a very complex network to our advantage and sometimes to our disadvantage. So when you have a mismatch, be it visual, vestibular, somatosensory, or all 3, contributing to this condition, we understand that's where the chronic non-specific dizziness can begin to come from. Now, as we'll talk more about later on in the presentation, you may already be putting together that with aging, a little bit of reduction in visual acuity and perhaps a little bit of slowing of conduction of the somatosensory information, which does this is an obligatory finding of aging. We will have a slowed speed of conduction coming from the sensory system into the brain as well as the motor system out. So our loss of some myelin coverings at the nerves is going to lose some insulation and then cause that conduction to slow down. So if you lose a little bit of visual acuity, lose a little bit of speed and reactivity and conduction velocity, and then also you've had a little bit of an impairment to the vestibular apparatus of one or both inner ears, or remember, you will have some conduction velocity loss there as well. With aging, a little bit of impairment across any of those 3, or an accumulation of impairment across all of those 3 would be a great way of describing the pathophysiology of what happens with the non-specific dizziness. Now, if we look at an entire list, and perhaps this isn't entirely comprehensive here, but a very good list of the different pathophysiologies of dizziness, you can certainly read there and understand that that's quite a complex and long list of different things that could cause dizziness. So again, this is listed to say that not everyone that experiences dizziness automatically has chronic non-specific dizziness. So just because you've attended this webinar, I don't want you to go out and start seeing that everyone has this. Because we can have unilateral or bilateral vestibular hypofunctions, neuronitis and labyrinthitis from bacterial or viral elements, cervicogenic causes due to neck trauma or due to an accumulation of arthritic changes over time, etc., migraine. Then also the 4th bullet point down, which you should be aware of, is 3PD, persistent postural perceptual dizziness. 3 Ps, persistent postural perceptual dizziness, formerly known as chronic subjective dizziness, cardiovascular, low blood sugar, and then finally presbystasis, which is really more of our topic for today, geriatric dizziness. So when we look at the complex nature of the connections that have to be made here laterally through the brain, it's not a great deal of surprise to us why sometimes things go wrong. And we understand that this is just a small list of the representations of different things that could actually cause the dizziness, more of a pictorial representation of a list that we've already been through. So to begin to more specifically rule in dizziness, we understand what it's not. and that should be a list for you now that is actually quite familiar. So the sensation of blurred vision that you see here, things being in motion, perhaps even the sense that you feel like you are not steady yourself because of that visual disturbance. That could be one thing we look at, and that's just, as you see here in this list, just a small subset of the different experiences and descriptions of the symptoms that an individual could have. So if we look at the entire set of dizziness, that includes all the terms that you see here, we can subset into vertigo, as you see in that circle, which has some overlap with presyncopal symptoms, which has some overlap with disequilibrium, feeling imbalanced, and this can be a great figure or pictorial representation for you to be able to compartmentalize the symptoms that your patient is describing to you. In some cases, it may be helpful to actually even print out this figure and share it with your patient so you can have a more comprehensive and accurate conversation. So we understand that dizziness has these three different potential columns here, and this is actually the terms that we used in that figure you just saw, noting that those terms that are listed in color actually are represented in more than one of the circles. And you certainly can turn back to this as a reference for you after the presentation today should you need more time with it. So if we look at this pathophysiology of nonspecific geriatric dizziness that now we've been really defining and honing in on, we know that a sensory loss because of somatosensory slowing, a unilateral vestibular hypofunction, which you might have had some time ago, decades ago in your life, and now the individual that you're working with is 70 years old, but they've been compensating quite well with great vision and good somatosensory processing for decades and decades and still dealing with a small unilateral vestibular hypofunction. But now they also have a gradual visual loss plus the somatosensory slowing. That's going to equate to that mismatch or conflict that we were talking about in the sensory symptoms. So if we look at the outline that we were talking about, the significance and incidence, and then moving down to the flavors and pathophysiology of dizziness, now we're kind of ready to take a look at subjective and objective examinations even more well after we define what is dizziness and what is not. So the different flavors of dizziness, a common phraseology, if you will, to use would be it would go from the most innocuous, feeling lightheaded, to imbalanced, to dizziness, to vertigo. So we certainly take a look at those different subcategories. And those should be pretty clear to you now given everything that we've gone through. Granted, our presentation is very short today, but I want to give you a great introduction to this whole concept. So if we begin taking a look at subjective and objective examinations, we understand that an accurate diagnosis using tests and measures to be able to clearly define dizziness and then to define movements that are intolerable, positions that are intolerable, guide us exactly toward treatment. Okay? So to be able to screen someone effectively and know for sure we've got dizziness, you need to be very familiar with, at the very least, these 5 measures or tests to do. Okay? Motion sensitivity testing probably can be very easily done with a dynamic gait, with a functional gait, but even more accurately with motion sensitivity quotient, which I would encourage you to become familiar with. So we'll look at actually some of these today on video as well. In terms of differential exams, to become a little bit more advanced in the presentation now, obviously you'd want to be able to clear all 6 of the semicircular canals, 3 on each side, with comprehensive positional testing. dynamic visual acuity, which if you're not familiar with, you need to become more familiar with, and is beyond the scope of just this presentation itself, but essentially your ability to retain your visual acuity even while your head's in motion in a comparison to your visual acuity when your head is steady, using something, for example, as a Snellen chart that you would find in the eye doctor's office. Now, other differential examinations, as I've already stated earlier, would include the CTSIB, and then further, as I've referenced already twice, the MSQ, as well as a great test to be able to rule in some dizziness would be head shaking nystagmus, and very easy to look up on that as well. But just to be comprehensive and to also be efficient, we'll move on. So the outcome measures, many of which we've already spoken about now, new to you would include the Dizziness Handicap Index, the VRBQ, and the VVAS on this list. You should be using those regularly in your practice so you can be not only accurate with the diagnosis, but also tracking patient outcomes. So as we move past the subjective and objective examinations, we're now going to look at the algorithm for treating dizziness. So with this algorithm, we should have a step-by-step application through your examination to understand exactly what provokes this person's dizziness. Is it walking with head rotation, walking with head nodding, both of which you'll actually find on the DGI and the FGA, that's the Functional Gait Assessment and the Dynamic Gait Index. You should be able to find subtests of those items and be able to rate and score those. Perhaps it's rolling over in bed and coming up to sitting. Perhaps it's sitting and nodding their head up and down. Whatever the set of conditions, movements, positions cause their dizziness, we're going to actually use those things starting there at number 2, determine provocational movements. We're going to ask them to rate the level of symptoms that they experience in any terms that they like. Fullness in the head, nausea, dizziness, etc. How bad is it on a 0 to 10 scale? Then we want to investigate the fatigability of their exposure to that very same movement, activity, or position. So if I do 5 repetitions of nodding my head up and down, and I rate my symptoms as a 2 on a scale of 0 to 10, now I want to try to do another set of those same 5 head nodding repetitions, and I want to re-rate that. And I'm looking for fatigability. Does your symptom scale or your rating go up or down with that? And if we can use that as part of your rehabilitative process, we'll know that you are going to have some fatigability. I'm going to prescribe you to do that activity as well as the other activities that are similar in nature that provoke your symptoms to a 0 to 3 on that symptom scale. To be clear, I'm not going to be using as a home exercise or clinical exercise activities that cause you to feel that you need to rate your symptoms as a 5, 6, 7, or 8 through 10 on that 0 to 10 scale. So I'll ask you to do it 2 to 3 times or more per day in 5 repetition sets, and then we'll begin to advance your prescription by giving you more difficult, more complex, more challenging activities and taking away those that no longer provoke symptoms. So we have the accurate diagnosis that we've talked about to this point. We certainly have the notion of what movements and activities cause your problems. Then you rate the level of symptoms. Those should be 0 to 3 if we're finding a great activity, position, or movement to prescribe for you. We want to investigate the fatigability over repeated exposure, prescribe it for 2 to 3 times per day in 5 repetition sets, and then finally advance things accordingly by taking away activities that are no longer necessary because they no longer cause symptoms. So determining the provocational movements and stimuli often fall in the categories of head motion, rolling over, turns in standing and walking. These can be sometimes very simple, like standing, eyes open, turn 90 degrees, turn 180 degrees, or turn 360 degrees. It could be head rotation while walking. It could be provoked by visual stimuli that we may use through a computer-based directive or potentially just watching traffic. So the diagnostic considerations, once we've defined exactly what provokes and what it is that we need to also understand that imbalance will come with dizziness, and confidence, feeling unsteady, unsure about engaging in an environment that provokes you, will be concomitant. Now, we need to understand that a lot of individuals will be more severely disabled by this initially because they've been splinting their own head and neck out of fear of dizziness, and so they'll get into some non-use that actually makes the symptomatology worse. And so gradually increasing the head in motion, telling them that it's okay to participate in these activities, and frequent exposure is going to actually be to our advantage as well. You will find, exactly as referenced earlier, that individuals will be severely visually dependent and over-dependent to the point of causing anxiety in some. And then, obviously, we need to separate out how we're going to do this with individuals that have experienced this for the course of months versus the course of years. And that's not unusual at all, but understanding that the time frame of rehabilitative efforts is going to be associated as well. You'll find that the rehabilitation potential for these individuals will be directly tied to some properties of their personality, anxiety, etc., intangibles of that nature, but primarily when you take a look at their tolerance to and the fatigability of the symptoms through habituation, you're going to know a lot about how quickly they'll recover. Obviously, the entirety of the rehabilitative efforts here is truly based on the brain's re-networking and rewiring, known as neuroplasticity, so that mismatch of sensory symptoms or this mismatch of sensory modalities becomes an equation that balances on both sides again. So as we understand, this rehabilitative practice that we're in is known as practice. And I'm going to show you a few video applications pretty soon here that are built largely in evidence and are actually pushing the envelope a little bit in our efforts to always get a little bit better and practice so that we can become perfect at this. So the evidence behind what we're doing is stated here. And we also understand that the neurophysiologic reorganization is as stated here. You can use those as reference points initially. Obviously looking here at the present and then also in the future, our success rate and sophistication of rehabilitation is definitely going to be increasing as technology increases for us as well. And so we'll be looking for benefits from some of these different aspects of advancements in the technology world to help us out as well. I'm already using posturography, visual assessments, accelerometry, force plate enabled treadmill. We don't use a lot of virtual reality in our clinic just yet, though. So in posturography, exactly as described here, we can dissect out what sensory systems people are using and not. We can use visual assessments that really truly afford a view into the vestibular system through the window that's afforded to us with the eyes by looking at different positions and movements and having individuals that cannot actually fixate and block out involuntary eye movements. We do accelerometry and motion analysis to be able to help us identify individuals that are truly having problems versus functional problems or somatizations, and as well as to document improvement. It is very helpful for an individual to see themselves actually improve through accelerometry and posturography that is a picture to say, here's how well you were balanced and here's how well you are now. Because there's a psychological component that will always be associated with these things because it's a really a condition that cannot be seen, people tend to question themselves. And when they can actually see themselves improve, it's psychologically very reinforcing. As referenced, and I mentioned, we do use a force plate-enabled treadmill to retrain some people to be able to get that direct analog feedback of their steadiness or instability either way. And then virtual reality is something that certainly we haven't tapped as much into, but is on the verge. So obviously all of our goals are fall prevention, and that's the main thing that we're shooting for there when we're trying to improve a person's functional capacities with regard to dizziness. With that said, I think we are actually ready at this point to begin to take a look at some videotape case studies. And with the first video you see here, we're actually trying to reduce this patient's visual dependence and improve his use of both the vestibular apparatus as well as somatosensory by giving him essentially a lie. We call this visual lies, which you'll see in the top left-hand part of the screen. If we cause the brain to distrust the visual system, it is going to induce some of that somatosensory reweighting that we were talking about. So changing the importance of the visual system as not such a dominant player. Now we're going to pull up the next video for you. And again, using the visual lies principle here, we're surrounding this patient basically in 270 degrees with no reliable visual input that she can use to compensate for her balance. So she's bouncing on the trampoline, and as you could see there, she was also engaged with that surrounding peripheral vision. Now we see this is the Brandt-Daroff, and when we're doing the Brandt-Daroff with a patient, we can also use this for habituation type efforts, and many patients will benefit from going through this on a routine basis. You'll see we turn the head right 45 degrees, lie down quickly to the left, allow symptoms to pass, then we'll have the subject sit back up, turn the head to the opposite direction, in this case leftward 45 degrees, and lie down to the right. This is typically done in sets of 5 or more repetitions multiple times per day to begin to more well assimilate movement throughout the body, head motion, and body motion together. And you certainly can look up the Brandt-Daroff then too, and we've got these videos available for viewing as well. With the next video, we see a patient that is trying to work on this multisensory integration where she's being requested to walk in a straight line on the treadmill, keeping her speed up on the treadmill. Notice that she's harnessed here just for safety while enduring some basically VOR1 and VOR2 motion. So here's vestibulo-ocular reflex number 2 with head and target in opposite direction and in motion, and the former was VOR1 with the target, the visual target still, and the head in motion. With this next video, we have a patient who's engaged in body weight support, and he's going to be explaining how he's walking, acclimating up to the speed that he's walking at, and then he's going to try to extend the number of steps that he can take with his eyes closed. So he realizes that he's trying to retrain his sense of balance and downgrade his sight of balance. And so we'll watch him engage here just a little bit with that. He knows with no degree of uncertainty that he will not fall with this, and that's what he's reassuring us of right there in the videotape. So he's describing what he's going through. He's got his speed up. He just said he's at 1.4. He's going to take his hands off so he doesn't get additional sensory information. and then he's going to try to close his eyes and take the greatest number of steps that he can accomplish consecutively without having to open his eyes back up or hold on to the handles again. The type of body weight support unit you use here doesn't matter so much. What's most important is the patient is given that assurance of safety and can actually see themselves improve along the way. In the final video, with some tongue-in-cheek, we introduced this last video to really just kind of keep it real and to allow patients to work on task-specific activities. Obviously, in this case, we called it body weight-supported ballroom dancing. This is something that if we just had the patient just march in place or step forward, step back, it might seem somewhat trivial or trite. However, the patient was certainly very invested in his efforts to do the ballroom dancing. So again, keeping it very task-specific in something that is entertaining, meaningful, and engaging for the participant is basically the reason why I wanted to show you that last video. Not that everybody wants to go out and do body weight supported ballroom dancing, but it was a meaningful activity for this individual that allowed him to re-engage in everyday life. With that said, I certainly wanted to thank you for your attendance in the presentation today, and I wanted to share with you my contact information should you need to reach out to me directly and ask any questions regarding this presentation or to see any of the videotapes over, etc. It's been my pleasure to present this presentation for NeuroCom today, and I want to thank them and their staff for the support that I've been given. Thank you.
I'd like to thank Mike Studer for his helpful and informative presentation. Please visit nervecenter.natus.com for additional learning opportunities. Thank you.